The National Health Insurance Bill has passed in South Africa's parliament, marking a significant step toward universal health care in the country. The NHI aims to provide comprehensive health care to all citizens, addressing the existing inequalities in the system. However, debates persist regarding the advantages and challenges of this revolutionary legislation. Supporters argue that the NHI will bring much-needed change to a healthcare system characterized by disparities. It is seen as a means to promote health equity, improve efficiency, and enhance the quality of care. Critics, on the other hand, express concerns about the potential administrative and funding challenges. They point to the government's track record of poor management and corruption in public sector entities, raising doubts about the effective and ethical administration of the NHI. And that's why we're having this conversation on the NHI on the Square today. I am Kemeni Amano, and you're welcome to the Square. Joining us from South Africa, Dr. Angelique Coetzee. She's member of the South African Medical Association. She's also advisory member of Solidarity Doctors Network, and she's joining us from Pretoria. We also have Russell Rensburg, who is the Director of Rural Health Advocacy Project in Johannesburg, South Africa. Ladies and gentlemen, you're welcome to the Square. I want to start with you, Doc. Talk to us about what the key objectives of the NHI is and how it will address the existing disparities in the healthcare system.
Look, thank you for having us here. You already said that, that the National Health Insurance would like to restore the inequality in the healthcare, giving everyone the same healthcare outcomes, treatment. There should not be a difference whether you get it in public sector or private sector. And that is a very, very noble idea. And I don't think that any doctor can find fault with that. However, we call this universal health coverage. Currently, all South Africans do have access to the healthcare facilities, whether it's to the public, to the private, whether it's through financing out of their own pocket, or whether it's through medical schemes. So the problem that we are having is with the bill itself in its current format. You also mentioned right in the beginning the corruption and the lack of trust that there is between the healthcare fraternity and National Department of Health. I would love to see a place where a patient can come to me who doesn't have money. I can treat him on the public sector leg, if one can put it like that. I can order his bloods. I can make sure that his X-rays are in, are done that's needed. I can give him proper medication, and he can be on his way. And then for someone else who pays me through a medical scheme, I can do exactly the same services. That would be the ideal, so that we, as doctors, would be able to treat each and every one at the same level with the same outcomes. However, we don't think that is what's going to happen under the envisaged National Health Insurance
I see.
bill. Also, please remember one more thing. The National Health Insurance is actually a funding model and doesn't tell us anything about the care that we are going to provide or how it's going to be provided.
I see. We'll get a bit more into some of the issues you've raised, but I want to move on to Russell. Now, Russell, let's talk about rural South Africa and what this bill could mean for them as it is now.
Yeah. We just make sure that I'm not on mute, I still got pandemic vibes. I often talk while still on mute. Look, I think healthcare and health are very different things, right? And, the South African National Health Act provides a broad framework that the government or the state has a responsibility to deliver healthcare services to all of the population. Currently, we have a parallel system, right? We have a publicly funded system of over 600 hospitals and includes large tertiary complexes, central hospitals, specialized hospitals, district hospitals, and over 3,500 clinics. I think they employ close to 500,000 people, and they deliver healthcare to 80% of the population, right? But the way that the healthcare and the way that the system is structured, and I'm talking about the public sector system here, actually doesn't support it to deliver on key population health outcomes. So one of these goals is really to sort of accelerate South Africa's journey onto universal health coverage. And when we talk about universal health coverage, we look in terms of SDG 3. We know because healthcare is like, as a long list, healthcare needs are unlimited, right? But the things that we focus on in the that focus on in the SDG 3 are essential health services, like services, access to reproductive and maternal child health, eradication or control of infectious diseases like HIV and TB. And of course, the big thing that none of us are really figuring out at the moment is non-communicable diseases. Not so long ago, we had the COVID pandemic, and the bulk of people who died during that pandemic were people who had uncontrolled diabetes. And that's something in South Africa, it's more than 5 million people that live with diabetes. Less than a quarter of them are currently on treatment. So when you look at the public sector and the private sector does an excellent job of delivering care, right? But it doesn't have any population health responsibilities. It's really very much a consumer model. You have healthcare. If you have healthcare insurance, you go to the doctor when you're sick, be it for flu or be it for whatever you think it is. All the data that's collected in the private sector is not shared in national data. We have to get special requests to get that data. So overall, the contribution of all that effective care in the private healthcare doesn't really show on a population level. So as we understand it, in rural areas, we are probably the worst off, right? Because in rural areas, there's no private sector, there's no medical scheme coverage. So we are almost completely reliant on the state. And we know hospitals are sucking up, our inefficient public sector hospitals are using up more than 60% of publicly funded money. There's very little money to address the massive gaps in effective coverage that we have with respect to maternal and child health. We have higher maternal mortalities in rural areas compared to the urban counterparts. We have lower vaccine coverage of children under 5 in rural areas because of where we are and the amount of money and skills that we have available. So I think the inequities are endless. But what we need to do to address our problems as a country, we can't say because it works for the 20%, we must just leave it like that. We need to, as a country, start looking at a way that we can manage a unified system. And I don't think the NHI is maybe the panacea for that. But we all know that the money follows the function. And when we start reorganizing how the money in the public sector is set out there, the better we can target our interventions towards the areas that we need more attention. And the better we can do a job of making our publicly funded hospitals much more efficient, with their own budgets, with their own boards, and with their own accountability.
Well, Russell, the bill as it is now, does it provide all of these things that you have spoken about?
What the bill does, firstly, in this bill, it does 2 things explicitly, right? So the first thing is it creates the National Health Insurance Fund, right? And the goal of this fund is to consolidate all public sector expenditure in the short term into a single fund and change the way that funding is distributed through the system. The second thing that it does, and it prioritizes this, is the establishment of district authorities and the creation of what they call contracting units for primary care at a sub-district level, which would normally be a care network comprising a district hospital, which we have, clinics, which we have, as well as an additional layer called an integrated practice, which is a combination of healthcare professionals that work in support of the system, but not necessarily in the system. Like I said, at the moment, we have almost 0 GPs operating in rural areas because there's no medical aid penetration. This integrated practice, at least in theory, suggests that now we're creating an envelope of money that would make it feasible for young doctors or doctors to come and establish their practices in rural areas. That's not something that's available to them at the moment. So at the end of the day, I think it's really about reorganizing the system, putting priority on primary healthcare, in particular up to the district level, and expanding population coverage to the VSA.
Indeed. So
The rest of the stuff will be
it does come back to the point that Doc has made about the NHI at the moment being a funding model rather than telling, really stipulating. Absolutely. And so I want to come back to Doc. What would you have liked to see the NHI do as far as, giving directives on how functional the health system should change?
A very important question. So I think what is also important is to understand that you cannot take the public sector and the private sector and just want to throw them all into one system. You need to take the best of the public sector, the best of the private sector, try to see how you can mitigate and uplift. If there's good services in the public sector, you have to uplift the private sector to the same level. You cannot bring everything down to a poorer level, and that's what we are seeing. Plus, what we need to do, we need to start practicing preventative medicine. We do not do it. Our people in our country are not used to preventative medicine. They only access services, whether it's public or private, when they're really sick. The cost to treat those patients when everything falls down is extremely high. We need to be more preventative. Then we need to teach our younger doctors.
Russell, we can hear you, so it's interfering with what Doc is saying. Doc, go ahead.
We need to also train our younger doctors not to be so hospice-centric. They're very, very hospice-centric. They struggle to look holistically at the patient, to do preventative medicine, to look at the outcomes. They're not trained that way. It's not their fault. They're not trained that way. Even if you bring in, at this current stage, NHI funding the doctors to go and work in the public sector or in the deep rural area, there is unfortunately not studies done showing what it would actually cost to set up such a surgery there, the difficulties those doctors will experience, and that's actually one of the bigger reasons why they're not in these deep rural areas. There's lack of roads, lack of transport, there's not infrastructure, there's poor electricity. You sit with a lot of those structural problems. Well, it's easier to actually practice in a urban area where there's better infrastructure. So yes, there are medical scheme patients, but what we also see at primary healthcare level in the private sector is that a lot of patients can't afford their medical schemes anymore, so they buy down. They will rather pay you cash, and whatever they can claim through the medical scheme, they will claim, but they are willing to pay out of their pocket for a better service. And I think if you look at the NHI or how National Department of Health is envisaging it, is that they want to be the purse string keeper. They want to tell patients where you will go to, what services you can get, and what you can't get. And if you look at that, I would like to remind the National Department of Health that we have a right to access, under our constitution, we have a right to access healthcare services. But access to healthcare services doesn't mean I get treated. I always say it just means I can access it. Our people in our country have access, but they don't have good care. There are pockets of excellence, even in the deep rural areas. There are public sector hospitals that are excellent. There are excellent private sector areas, but don't think everything in the private sector is good. It sometimes looks so good because it's so bad if you compare it with the public sector. But there are good people in both sectors, and we need to work on that. And we need to rather get to a situation where, as I've previously already mentioned, where we uplift the sectors to give good healthcare. We don't need to reinvent the wheel. They're going to try to reinvent the wheel. It's not going to work. They don't have
Indeed.
proper electronic health record systems. Administrative, it's going to be a nightmare. But yeah, it's not difficult to change this. You just need to have political will. You need to employ good people. And you need to put your foot down and say, this is how it's going to work.
I'll come back to you. We know that on the record, Health Minister Joe Pala has said that would need 200 billion rand to fix the existing system. So even before we think of doctors opening up practices in hard to reach areas, the existing system would have to be beefed up, so to speak. Now, my question now is, and that's to you, Russell, if you could tell us, explain to us the current state of, the health system for hard to reach areas in South Africa now, and whether or not authorities are doing enough to change that.
I don't think they're doing enough. Obviously we've been going through a descending financial crisis for an extended period of time. One could say even since 2012, where we've underfunded the health system, right? That underfunding has led to even, how can I call it, prejudice within provincial departments of how we allocate health funding, with the bulk of the funding going to urban areas. And because rural areas are far removed and the population is largely poor and don't necessarily always have a strong political voice, they're the last end of the chain. So we're underfunded, we're understaffed. Services are generally not quite what they need to be, and that's why we're so anxious and ready for improvement. And with some decentralization where authority can be given to district hospital managers and district teams to sort of sit and say, okay, here's your budget envelope. How would you best spend it to ensure that you meet the outcomes that you need to do? How will you make sure that you can invest in the right kind of data systems, that you stop doing the things that are inefficient and doesn't contribute to health? But a journey of 1,000 miles will always begin with a single step. But if we've learned anything from COVID, right? Disease is universal. Everybody could get COVID. That's why in the first couple of months, we were all very, very concentrated on trying to contain this pandemic because we knew it affects all of us. Unfortunately, the patients that live and work at access care in the public sector sometimes are not that important. When I look at tuberculosis, which is the disease of the poor, we've done terribly on it, right? Across, we don't even treat it in the private sector, right? We just treat it in the public sector. We have over 300 people 1,000 people that acquire TB each year. Only 100,000 of them or less get access to care. And every year, a large majority, a big portion of them are still dying from a preventable and curable disease. So the model of how we deliver healthcare, where we set up these facilities with we can clean the floors, we can have great filing systems, or whatever you want to call it. But if we're not doing something like Dr. says around preventative medicine or health promotive medicine and reorientating how primary healthcare works, the problems that we have in rural areas will continue. Because our biggest problem is building trust in the healthcare services, is making sure that the healthcare services are responsive to the needs of the communities that they serve. And more importantly, we need to prioritize that we speak to the people in the language that they speak. Often when we're accessing our healthcare services, people need a translator. So their first point in the rural areas is often traditional medicine, which is not necessarily always a great thing. So I think reorganizing and putting more power into the hands of local authorities that are well resourced and well governed, we can start changing the shape of the health system, particularly at the primary health level, so that we can do the kind of things that Dr. Kutsi is talking about, of more preventative medicine,
Indeed.
Of more health promotion, of addressing some of the social determinants of health more explicitly, like giving food parcels to under fives, if there is a need in that province where we are. Last week, I went through all our old district health data, and I was looking at what are the leading causes of death in many of the rural districts. And malnutrition was still massive. Protein malnutrition, diarrheal diseases among young children, which is all socially determined, drownings, interpersonal violence, which maybe speaks to the fact of how good is our emergency services in those hospitals to be able to get people who are injured with road accidents or through violence to be able to have their lives saved. So our system is unequal. It's not perfect. This legislation in itself won't solve all those problems, but I think it does create a framework for us to be more specific about the problems we're trying to solve.
Indeed. When we come back, I want you to address, the issue or what could be the challenge with finding the health care workforce, if this goes full gear, whenever it does. I also want us to look at the sustainability of the funding model chosen by this bill when we return. Don't go away. You're watching Village Square Africa on News Central TV. Today, our subject for discussion is South Africa's NHI. Still with me are Dr. Kusia and Russell Rinsberg, both of them joining us from South Africa. Ladies and gentlemen, thank you so much for your patience on the program. Doc, I was saying, how this could impact the general healthcare workforce in the country, and indeed, whether or not the numbers exist for this bill to be fully functional.
It will be very nice if we can understand what this bill entails in terms of monetary value. We only know that everything is going to be put into a pot, but more than that, we don't know. So it is also difficult to say what they are going to pay for and not. So this is a pot. It is like licorice, all sorts type of sweets that's in the pot, and we also don't know what we are going to get. But what is important, what should first happen, is the monies, whatever monies be allocated, should not go at this stage to get, buying services of doctors and buying healthcare and say, you can only treat diabetes now and this is the medication. What first needs to be done? We need to train the nurses. We need to move into getting more registered nurses. I was sitting this afternoon in a what we call a cluster meeting of hospitals. And this is big hospitals I'm talking about. And they've got a dire need of nursing staff for theatre. There is not enough nursing staff for theatre. We need to make sure that the health workforce is first of all sustainable, are correctly trained at the right level for the right job. We need to make sure that our young doctors, if you want to attract them, you need to make sure that if you want to get them into a public sector hospital, make sure the infrastructure of that hospital is working, make sure there are enough senior consultants which can help and assist them. If they go into private practice, make sure that we have a set standard. We know that the Office of Health Standards are looking currently at how practices should be. But, it's a very long document, and I don't think that document is going to be getting the attention it needs from the doctors, because it's quite complicated and no one is paying us to get our surgeries up and on that standard. So government needs to play a role there. We need to look at electronic health record systems. There's good systems in the private sector. We need to be able to get those systems interoperable so that whatever I do in my surgery can be, on a national database surgery, so that we do not duplicate work. We need to make sure we've got enough specialists. We need to got enough GPs. I can promise you we don't have enough. So there's a lot of we just need, first of all, to fix the human component. Then we need to fix the infrastructure, because it doesn't help us to say we have 20 beds, but there's no staff. 20 beds doesn't mean anything. there's a human component and an HR component around those 20 beds. There must be enough finances available. We need to make sure that if you want to do a capitation model or whatever model the government's got in their minds, needs to look at, again, what does it cost to set up those facilities? Because in the public sector, National Department of Health will foot a part of the bill. Other departments would foot another part of the bill. They're not speaking to each other. We see that is part of the infrastructure problems that we are facing currently. But again, we don't know what the cost is of running a private practice or a private hospital. Maybe more than private hospitals, but private doctors, specialists, GPs, not even talking about the allieds. What is the real cost of running such practices before you're trying to say to us, listen, we will capitate you on a 200 Rand a month, and that should be it. We haven't done the basics. So we know there's a funding model. We cannot tell you what is in the funding model, what it's going to fund. Not even National Department of Health can tell us that. And that's very bad. You want me to look into your system. You want me to be part of your system. You've got a very bad track record of trust. We've got a good record of corruption. And you can't tell me what you're going to do with me. You just say, you will provide these services. We will employ you, or whatever means they want to pay us with. And
Very well.
That's it.
I want to take, indeed, I want to take those numbers to Russell now. Russell, as Doc has said, we really don't have an idea of what the numbers are, but we do know that based on the model that the bill stipulates, taxes will be used to fund the bill. We also know that they expect some employees to pay, and also taxing the rich and wealthy of South Africa. My question to you is, how feasible and sustainable is this choice that the bill has made? You're muted.
I think that's the important thing.
Right, I can hear you now.
Yeah, we're not starting from zero, right? We're not like today writing something on a little drawing board and say we're going to do this, right? Currently, we have a very complex system. We have, like I've explained earlier, there's a massive publicly funded health infrastructure that costs money, right? So from state or from tax revenue raises to taxes, I think there's already 260 billion Rand in the kitty, right? Add to that, one of the things that could happen in the short term is the withdrawal of medical scheme credits, which could add another 40 billion Rand to that. So in the short term, to restructure the public health system, they would probably look at 360 billion Rand a year. Again, on what services are offered. Our constitution talks about the progressive realization to the right to health, right? And our Health Act goes further, like by focusing more specifically on primary health care and the kind of services that are offered at primary healthcare up to district level, right? We never envisaged the system to be entirely free in the early days, but currently we're running an entire health system or health service for free. People don't pay for anything from a liver transplant or this, that, and the other, right? So I think we need to find a more effective way of utilizing our resources, right? We have to find cost efficiencies. We have to make sure that we have good hospital data systems so that we can understand what's happening and what we're doing and what are the things that we do inefficiently and what are the things that are probably better done elsewhere in the system. So I don't have a crystal ball, and I don't think you can cost the entire, I think there was a costing done in 2011 and it quickly expired because medical costs are rising at an incredible rate. So the overall costing, I think I can't answer. I think in the short term, there is money. I think they need to start looking at how they organize that money. Our hope is that more money is prioritized to district health systems, that we find mechanisms to contract in private practitioners in areas where they're underrepresented. And I think at the end of the day, it's going to be about fair value. Similarly, in medical schemes where we are at the moment, doctors don't get paid the same rates by all medical schemes. There's not one universal standard rate that will pay for all GP consultations, X, Y, and Z. Right. It depends on the scheme. So not to expect that the government must come up with a rate that we're going to pay you when through the 67 schemes, each one of them pay you differently, I don't think is necessarily a very good way of criticizing the lack of information in the system. But what I do think we need to do is have more dialogue, right? This is only the first stage in a long 14-year period of implementation of these reforms.
Absolutely.
I think we need to develop our positions more explicitly. We haven't amended, or the country hasn't presented the medical schemes amendment bill. We haven't spoken about to the broader health professionals around how we will look at contracting. So all of those things are not covered in the bill. The bill,
except that, associations within the healthcare have said we have spoken, we have the dialogue, but these things haven't been paid attention to.
Yeah. The point is, this is a bill to develop a funding model, right? Just to create an organization and a structure. There's still 37 amendments to the National Health Act that needs to happen in order to answer the questions that are not included in the bill. So I think it's disingenuous to say that we've consulted on this, but if it's not in the bill, where will it fit in? And I don't think this is the end of the road, and I think these conversations need to happen.
And I agree with you, Russell, but what I'm saying is that it's only a sign that the government isn't listening.
No, the government's listening. In fact, private practitioners have taken the government to court on when they introduced the minimum fee bill, right? These discussions are not new. I think we've been going to and fro on conversations with separate organizations, and us as patients, we're just standing on the sidelines, right? And I think at the end of the day, we need to come together as a country, understand that our health system is not efficient, that it doesn't work for all, and that the conditions in the country is not great everywhere.
Indeed.
But in the national interest and in social solidarity, I think as professionals, we need to come together and try and figure out what is the path to implementing these reforms in a manner that is agreeable to everybody. But not everybody
I want to take that to Doc now. And Doc, you can weigh in on a dialogue with the government regarding the bill. But I also do want to ask you, there are those who would say, and for argument's sake, that the doctors are comfortable with the private schemes and do not want to saddle themselves with public scheme, which is, really important, as we have all agreed on the program today. What would be your reaction to that?
Well, first of all, my reaction was I was the one that presented the changes and the concerns from SAMA's side to the to the Parliament, and we made quite a substantial, or we asked for changes. We showed where the concerns were from our side, and none of that has been addressed in the new bill. Actually, very little of the input that was given has been addressed in the current bill. So sometimes we need to be also cognizant of the fact that tick box type of behavior might be at play. I'm not saying it is what happened here, but so you will hear medical schemes, all the people who gave submissions to the Parliament, they will tell you none of that, or very few of their recommendations has been listened to and been put into the bill when they relooked at the bill. So that's one thing that I think it is important to understand. Second thing again, it is true that the medical schemes are at this stage going to, if they keep on increasing their monthly subscriptions, you will, in the end of the day, not be able to afford the medical schemes. I'm always saying they're going to price themselves out of the market. But I think what is important is for government also to listen to what the Health Market Inquiry said regarding private healthcare and start to implement that. They didn't listen. They didn't implement anything on what the Health Market Inquiry advised us. So we think maybe one of the reasons why they didn't act on it is to say, listen, see, the private sector is very expensive. The private sector, the cost, look how the cost is going through the roof. But what did government do regarding recommendations? Actually nothing. So again, to come back to, will I trust National Department of Health currently in the current situation? It's very, very difficult. We as general practitioners, we have not been approached by National Department of Health to sit with them. And then what Russell said is extremely important. We need to talk, even if we talk for the next 2 or 3 years, but we need to talk, we need to tell how we see primary health care. And you need to speak with the people who's at the coal front every day busy with primary health care. It doesn't help you to speak with the profs and the universities and all these very, very important people, because they're not at the ground. They don't know what we are seeing. And yes, our people are struggling. They're struggling to afford medical schemes. We need to look at a better plan in healthcare going forward to give better quality care. Always remember what I'm saying. Doesn't help you've got access. The term access means I can walk into a place, I've got access. Does it tell me anything about the care? No, it doesn't tell me anything about the care. And we need to look at that. We need to bring guidelines in there. And we need to make sure that our people get what they deserve.
I see. Now, Russell, one of the things that, took me by surprise is the timeline associated with this bill, which is something you have also mentioned, that there's a long way ahead. We are looking at a 14-year period for full implementation. That sounds like a lot for South Africans who cannot afford quality health care at the moment. It would seem as though this is just to tease them for now. What exactly do we mean when we say that we're looking at a 14-year period for full implementation?
Well, first, I think because they're looking at it as a phased implementation, right? I think the immediate priority is to fix district health services. And that's why there's special mention of that in the bill, and district health services, primary health care, right? And I think Dr. Kutsi mentions the health market inquiry. That didn't deal with the public sector. It just dealt with the private sector. And part of the reason that it was only published in 2019, and the next year we had the COVID pandemic, but it was only published in 2019 because it was in the courts for 2 years, with medical schemes taking exception to.
Russell, we lost your audio. It would seem we can hear you. We can hear we can hear you now. Go ahead.
The thing is everything is guided by law, and law is always about perspective. Right? We have a clause in our constitution, which is Section 25, which really covers property, intellectual and otherwise. And linked to that is the law of contract. So when you're going about and you're reforming a massive reform of an industry that's worth over 500 billion, 280 billion of that being in the private sector, and the doctors themselves don't benefit that much from it. It's big medical scheme, administrative companies, big hospital groups, and the like, we're controlling the narrative. Indeed. So I can expect more and more, litigation around this, like we saw in the health market inquiry. And many of those reforms in the health market inquiry now, post-COVID, are beginning to be addressed, right? So I think these reforms will be happening parallelly, in a parallel way. But 14 years is to allow for all of these reforms and conversations to take place. But it may take longer because a lot of the stuff will end up in the courts. Because at the end of the day, all of us will try and protect our interests. As rural advocates, I think for our end, we hope it's sooner rather than later.
Indeed.
And our focus now is really just on the public sector reforms, the strengthening of district health management teams and the governance at that level, and really start beginning to reorientate primary health care towards the needs of the patients that they're meant to serve.
Indeed.
Thank you. Over.
Very well. I like how you say over, but Doc, I give you the last word on this one. Look, like you said at the beginning of this conversation, South Africa does not need to reinvent the wheel. There are examples abound outside of the continent, but we've also seen the implications of how things have gone for places like the US that allowed medical schemes to take charge of the conversation, and how things have gone for places in Europe, like in Germany, where there is good universal health care. What are the lessons that you expect that politicians will learn from these two examples?
Well, I hope politicians will learn. Just one comment before I answer you. 14 years from now, I will be nearly 80, so hopefully I will sit on the chair outside and look to what I call the circus going by. But what can they learn? They need to learn that you need to make sure that you have everyone on board. Also remember, even in England, the private or the medical schemes, they've got a insurance or assurance leg as well. And apparently that is increasing. More and more people buy private insurance to make sure that they get into the system. Also in some of the other countries, there's no country that only says to you, only the government can give you healthcare. You cannot pay out of your pocket, and there's no other way that you can access care. They need to listen to that, and they need to listen to the people like us who are at the coalface, people like Russell, who works with the public sector predominantly, people like us who work in the private sector, and we need to sit and see how we can make life easier and better for all our people. I do not want my grandchildren one day to say, Ma, you didn't help. You kept quiet. We have to fight. We have to make it right. And hopefully, if we build all the bridges and everyone had vented and, and the boxing gloves are off, we then sit like adults around the table.
Indeed.
And do what is the best for our country.
We hope so too. This conversation, like we have said, it's not ending today. There is a long haul ahead of us, and we hope that the right decisions are taken for the people of South Africa. Dr. Coetzee, Russell Rensberg, thank you so much for your time here on the program.
Bye, Dr. Coetzee.
Indeed. That'll be all this week on Village Square Africa. Remember that we're back on your screens on a Monday, same time here on News Central TV. I am Kemini Amano. Bye-bye.